I appreciate all of the dedication and work and the collaboration that came from this committee. I think early on, everyone heard me say, you know, let's try and find resolutions so we don't have to go to legislation. And I think we accomplished quite a bit. And in the course of the task force timeline, we were able to produce 3 pieces of legislation that I find to be the most effective to support our Delawareans, our businesses throughout the state, and our court system. That being said, I want to do just a quick, brief introduction. If everybody can just, as this being our last meeting, I want to make sure that it is recorded and we all know who was in attendance, and then we will kick off the work completed. So I'm looking at the screens right now. So when I call your name, just please say who you are and where you're from. Renee, you're the first person I'm seeing.
Court of Chancery.
Sorry, you did not come through clearly.
I am Renee Kinsey from the Court of Chancery.
Thank you. Lexi?
My name is Alexandra McFassel, and I'm the Public Guardian from the Office of Public Guardian.
Representative Smith?
Representative Mike Smith, representative of the 22nd District.
Brian?
Brian Bailey, Deputy Director, Division of Aging and Physical Disability.
Suzanne?
I'm Suzanne Siebert. I'm from the Elder Law Section at the Delaware State Bar Association.
Master Griffin?
I'm Pat Griffin. I'm a Master in Chancery.
Barb?
I'm Barb Little. I'm the Director of Care Management for Bay Health.
Vicky?
Vicki Cox, and representing Delaware Healthcare Facilities Association.
Patty? Oh, we can't hear you, Patty.
Good morning, Patty Resnick, Vice President of Operations for Christiana Care.
Thank you. Stephanie?
Stephanie Lancaster with the Developmental Disabilities Council.
And Judy?
Judy Schock, Office of Management and Budget.
Great. And Stacy?
Stacy Marvel, Chief of Operations with Division of Medicaid and Medical Assistance.
Thank you. And then, of course, we have our support staff on, which is my legislative assistant, Alexa Adams, Taylor Hawk, who is our policy director. We have our group from DTI, and I did just see Representative David Bentz joined us. And my
Hello.
Alexa just went off.
Good morning.
David, you didn't come in clearly. Could you just do it again?
Oh, hi. I was just saying good morning. Sorry, I was a couple minutes late.
No worries. We were just recapping introductions, David, since this will be our last Guardianship Task Force meeting. So let's talk about the work completed. Everybody has the document in front of them? Fantastic. So work completed. Number 1, educating primary care physicians and hospitals on the guardianship process. One of the examples that came up was develop sample physician affidavits that are available online in one-page summaries on the filing fees, processes for hospital personnel. Questions, any comments in regards to that? Seeing none. Number 2, improve access to court-appointed guardianships for individuals residing in a nursing facility. And so we amended the state plan of the Social Security Act in the state of Delaware to allow individuals residing in a nursing facility to use their, and then of course we had either their gross income or personal needs allowance to pay for guardianship fees. I know that took us several conversations, but we have some great people in our Medicaid division that were able to figure out how to clearly and concisely deliver that for us, and that came through the state plan. So thank you to Steve, Lisa, and Stacy. Questions, concerns? I'll stop at each point just in case, just to make sure that we are recapping correctly.
And Senator Poor, we had those brackets like that because we wanted to make sure we had the most accurate information. So first earned income is preferred over personal needs allowance to most accurately reflect the state plan amendment. That's what we were really seeking here, is just to see which one. And, you know, if there's someone from Medicaid that wanted to clarify that.
So I know we have Stacy on. I believe that was a Steve Groff decision on that, but Stacy, can you answer that for us? Do you know?
I was hoping Steve was going to be on. He was in another meeting, so I don't know if he'll join us later. I feel like we're protecting their gross income.
Okay, so we can follow back on that.
Okay.
So let's just we'll table this for until maybe Steve can jump on. Patty, I see your hand up. Oh, you're muted.
Sorry about that. That was the question I was going to ask. Which one are we using? And maybe we need to just have a subgroup meeting so that the hospitals are aware of how to do that. Like when they're working on guardianship, who actually takes care of applying those funds, those resources? Like what's the process so that we ensure that those resources can be applied? I'm not sure we know how to do that, Barb, unless you know how to do that. No, okay. So we just need some follow up on how to do that. What's the process for doing that?
To me, this is something that is, once somebody is opened in Medicaid, that we will protect their income. Every recipient will continue to keep their personal needs amount. That's why I said we're looking at protecting the gross income. But that doesn't really come into effect until once we have determined someone eligible.
Okay. So Stacy, maybe we could just follow up with you afterwards so the hospitals are clear on that.
Okay.
Thank you.
Okay.
Senator, it looks from the information, it looks like it's deducted from the gross earned income, but Steve would be the one who would be the ultimate source, but that from looking at the paperwork.
Thank you very much. I appreciate that. So Patty, let me just circle back to clarification on what you're looking for, and then adding what Stacy is saying. So the hospitals, what you think is that you need to know who's applying. How does this work within the hospital? Who applies for the funds? Stacy's response is that once someone opens up the Medicaid application and they are eligible, then that deduction starts happening. So I'm trying to follow. Go ahead.
I'm sorry. No, I'm sorry. Go ahead. I didn't mean to interrupt.
No, so I'm trying to follow your thought process on I guess the hospital's needing to know that information. Once you get the eligibility, isn't it already there?
That's what I wanted to know. But at our last meeting, so we talked about the patient who comes in, is in the emergency room, has no one to speak for them, and they cannot speak for themselves. And we talked about these funds being available so that a private guardian perhaps could take their case or their situation. So how does that work? So what's the process if we said, okay, we're going to have a private guardian step up and there are funds available through this process? How does that actually work after Medicaid eligibility is determined?
Lexi, your hand's up. I'm feeling like you know this answer.
So my
me,
understanding, my understanding of how this would work is, as Stacy said, once a person is Medicaid eligible and you have a guardian appointed, what you do is you pay the nursing facility, you pay the P&A, and then you pay yourself as the guardian from the funds. that would normally be going to the nursing home. So that's my understanding of how it works. I mean, obviously we would want to pin that down, but that's my understanding. So it's not something that happens prior to, it's when the guardian's appointed and the person becomes eligible for Medicaid, then those funds are available to the guardian to pay themselves in addition to the other bills. That's sort of how I think it's working.
And Patty, what I'm hearing you say is that
Thank
you
you.
would, Patty, if I hear this clearly, what you're saying is you would like to see this written out. What does this look like?
Yeah, exactly.
Okay.
Yeah.
All right. I think we're all on the same page of what we think is going to happen. You're looking for it to be more concrete, A, B, and C. So that way there's no confusion. Suzanne, I see your
And so
hand.
that everyone's not interpreting it their own way, right? So Bay Health's not doing it different and Christiana is doing it different from BB. I think it'd be helpful just to have a document that's the guiding principles, or this is how this works.
Got it. Suzanne, your hand's up.
Thank you. So to build on what Alex just said, one of the proposed amendments is to also cover the $750 fee for the attorney ad litem. So that's kind of a retroactive, probably prior to eligibility. And it may delay a little bit the attorney ad litem getting paid, but I see that as a different issue. It's a one-time payment, whereas the funds, the monthly funds from earned income is ongoing.
I agree. I don't think the state took into consideration paying for the one-time initial fee. I think we agreed to assure payments would be made ongoing. Because we asked some of the private guardians, and we talked to Lexi, and we came up with a figure of $100 a month is what it costs. So I don't think there was anything for the initial.
I'm looking at the language, and it did say under 20620.1.4, it included the $750 for the initial establishment. Did something happen after that information was distributed?
Right. I'm looking at what in my paperwork is called attachment 2.6-A, page 4 addendum. And what I'm looking at, it says B, capital B, post-eligibility treatment of institutionalized individuals continued. So we're talking post-eligibility, and going down to F, for nursing facility residents, F2i, initial establishment of a guardianship to include attorney's fees, $750. So, I mean, I would have gotten this document from the task force.
Right. Yeah, let me take that back. I know this is our last meeting, Nicole.
It may not be now. It may not be.
Let's take that back, because I do not recall, and I just saw the SPA for it the other day, and it did not have that fee. So I don't want to misspeak.
Sure. And Stacy, maybe while Steve's in the other meeting, you can just shoot him
I
a
did.
text on this.
I did.
Perfect. I figured, without a doubt. Okay. All right. So number 2 right now, I wish we had an interactive document, because I'm looking at my document right now. Alexa, if you can just make sure that you're highlighting that yellow as unfinished, okay?
We're all good. We have highlighted so far number 2 and
Great.
yes, number 2.
No problem. Okay, so going to item number 3, address longstanding resources issued in the Office of Public Guardianship in order to decrease the length of time from referrals to case acceptance and increase the number of cases accepted. And so we talk about in item A, following the OPG to collect fees under Senate Bill 85. OPG will be able to fund personal resources to minimize delays in cases acceptance And acute care facilities would save an estimated of $644,800 annually, based on the documented average delays over 30 days and the number of cases accepted in fiscal year 19. So that's significant. Any questions, concerns on that area? Moving forward to number 4, establishing a legal framework for hospitals to petition for a court-appointed guardian for non-acute patients in an acute care setting for an extended period after having been abandoned by the family. So of course, we know under Senate Bill 246, hospitals are authorized to petition for a court-appointed guardian for such a patient after providing 2 notices to patient, the patient's surrogate, or the parent's family, if there is no surrogate, of the need to seek guardian for the patient. Questions, concerns? Okay. So now let's get down to the outstanding recommendations. So we are listed with 3 of them. And of course, it is educating primary care physicians on how to serve and assist patients who have cognitive impairments. So I'm going to pause there for a second and see if there's any feedback from this committee. Patty, you unmuted. You didn't even need to raise your hand. Saw it happen.
Well, I know maybe as a committee, we didn't address this globally, but maybe in the individual health systems have. So at Christiana Care, for instance, we have embedded case managers in our primary care practices. So they're the available resource to our providers to help them with this particular recommendation. So I don't know, Barb, what Bay Health may be doing, or with what BB or any other hospital, St. Francis, might be doing, but that is the way our system is currently handling this.
That's awesome.
We
Barb?
have some embedded care coordinators really focusing on chronic care management, and that would be in the Bay Health practices. The independent practices do not have that. But for our Bay Health Medical Group and our practices that we own, yes, we do have chronic care managers, and they can help with this.
Okay. Brian, is there anything we're doing on a state level?
No, ma'am.
So I would say that this is probably an area that should be taken back to your department. And how are we disseminating information? Maybe it can go on the website. Master Griffin, is there anything that we can do to promote this in your area?
I don't, other than having a better contact, like to have a list of contacts when we have issues that we would know with an APS issue, who can we contact to try to get information directly? That would, that's all I can think of.
Okay.
And certainly the healthcare providers, I think we have relationships with them. And the one thing I was going to add is through this committee, there was additional efforts made and to improve access for the parties regarding the process of establishing guardianships. Remember, we had added, put online some sample physician's affidavit. We put online contact information. So hopefully, I don't know if it's always looking for things that have come out of this task force, but there were extra. I think there has been very positive efforts to try to make it better.
Yep. And Brian, that's why I'm reflecting back to your position and things that we can do within the state to make it easier.
I understand completely.
Thank you. If you can just do a follow-up with us, that would be fantastic on what we've done, and then we can disseminate it out to this group.
Senator, can you repeat that last part again? There was some background noise. I didn't hear you.
I would love to, but that would be my dog barking, and he's in competition with me right now because there's obviously someone outside of my home.
Okay.
So I'm going to do my best. You know what? Give me just 1 second, please. Maybe Alexa, did you hear me? And you can. I think he's getting quiet now. Nope, not going to happen for me.
Senator, I think you were saying that you wanted to follow up from Brian or someone regarding what the state can do regarding information and posting information that can be educational in this area.
And this is Patty Resnick. I do want to clarify for Christiana Care, as Barb mentioned, it is we put embedded case managers into our primary care network, so there are owned practices. There is that gap for the independent physician. So something from the state level posted online would be very helpful.
That's awesome. Yes.
All right, Senator Poor, Alexa went over it with me. I have an understanding now. Thank you.
I appreciate that. Thank you. I apologize that I had to step out of the room, but it's quiet here now. So, okay. And so really it is about the communication, and I won't recap anything that was previously said, but really this is about communication and making sure that we have the tools in place so someone is not sitting somewhere for a year at a time in a facility that they shouldn't be in. Getting to recommendation number 2, develop ways to improve coordination, collaboration between healthcare providers, state agencies, and insurance companies. So if you can all see, it's highlighted for item A, where we're saying establishing a clearinghouse to improve, and then in our quotations, coordination programs and resources to make sure patients have the supports needed to transition to the appropriate level of care, or the efficiency when transmitting and processing claims. So I'm going to open that up for discussion on outstanding recommendations number 2. Maybe not.
Senator
Hi,
Ford?
Patty.
Oh, go ahead.
Patty, sorry. No, go ahead. You first.
I was going to say if no one raised their hand, that we were trying to see which most accurately reflected the goal of the task force.
Yep. Go ahead, Patty.
And this is Patty Resnick. As I recall, this discussion was around having some centralized mechanism so that patients or more so their families don't get to the point where they're just desperate and they can't figure out what to do, so they come to the hospital. So that was, as I recall, the intent of sort of this coordinated clearinghouse. It would be one source of expert information. These are all the things that are available to you in the community, and here's who can help you navigate this process, which I think would be just fantastic.
Yeah. And I think part of that could go on the website. Brian, this is going to go back to you, or at least have some type of, like you said, a roadmap to how to maneuver through this.
Would that include the facilities such as Christiana, or we want to take them out of the equation completely?
I mean, it could include the acute care facilities, right? I mean, we have a vested interest in partnering with patients and their families to help them navigate this. And we're trying to make that as simple as possible. I mean, I think, very, very simple, something like an infographic, just this is how, these are the resources that are available and here's who can help. And certainly if you're in an acute care situation, we absolutely have the responsibility for helping patients and their family navigate that.
Okay. Hi, Steve. Welcome to the meeting. Thank you for joining us. I know you were in another meeting. so
Yeah,
we
I
appreciate your time.
I apologize. I was at Family Services Cabinet Council meeting, but thank you, Stacy. And she was sending me some questions, so I hope we're up to speed. But if there's anything you need from me, please let me know.
Well, we will
I had
circle
not
back
gone
to you.
Yes.
Yeah,
Okay.
if you can just give us a few minutes, we'll circle back to you on that. Right now, we're on outstanding recommendations, number 2.
Great, thank you.
So, outside of, again, this just all comes down to communication. Outside of having some type of process written out, posted somewhere. I think Patty, though, and I'm not sure how to solve this, is how do we get that information out to somebody? So I'm almost wondering if it's something that can be embedded. If someone is become eligible for Medicaid, is it something that's embedded in the documents? Is there like a slick sheet that people have this process to be able to follow? Is it that if someone is admitted into the hospital, Patty, Barb, any acute care facility, that this is a 1-pager that when someone's getting discharged, maybe they have private insurance, but they're on that cusp of going into needing Medicaid, Medicare. I'm just trying to think of, because I think equally we all have to take responsibility in how we're disseminating this information. I don't think Brian putting it on, the DHSS website is the end all be all, right? Because if someone doesn't know to go to that website, they don't know that this information's there.
And Senator Poor, this is Barb Little.
Yes.
I agree that it's a collaborative approach, and maybe if we do have something like on the state website, but also, like you said, a 1-page sheet with information that we could give to people that we see are kind of moving in that direction, maybe to their family, and maybe to have that available in the primary care offices and the care coordinators as well, because it's a lot of times, the families, they get to their wits' end, and that's when they bring them to the hospital. So if we could get them starting to think about it sooner, I think that's a great idea. Yep.
Maybe one of the areas, and I apologize for not seeing this until now, is having someone who services the insurance companies a part of these conversations in regards to, because I would think that, if I'm signing up with Highmark, or Highmark's obviously contracting with the doctors, Highmark might be able to say, here you go, doc, especially if they don't have a care coordinator in their office, not the way the hospital systems are providing it.
Yeah, I agree. I think it's a great idea that we have a common educational tool so that no matter where the patient or family might be, whether they're in the acute care, in their primary care office, on the state website, it's the same information and the same messaging. So I think that would be a great tool.
So let me ask this question. Who in this group is willing to take a stab at putting something like this together? I see Lexi's face.
I mean, I can help. I can help from. I can help from the acute care side. This is Patty. I'm happy to help from the acute care side. Barb, you have an expertise in acute care and the payer background. Barb comes from a payer background, but we don't know the whole. We don't know the whole realm of the outside of that acute care setting. So we're happy to help with this. Absolutely.
So let's do this. Let's start it this way. Patty and Barb, if you guys kick it off on an acute care part, Vicky, maybe it's something that you and Cheryl can add to it. Steve, I would ask, could you look at, kind of being the third party that's coming in? Maybe we can do it as a Google Share Doc, right? Everybody's putting their little piece in. And then Brian, of course, you would join that. From that point, then we can finalize it. Maybe that's what the one piece looks like. Because there's so many moving parts to this. And you don't know what you don't know. As a family member, you don't know what you don't know. So I'm not necessarily sure I'm going to a particular website. I might Google some things. But if each of you are disseminating this information, but it's been a collaborative effort, we're all on the same page. Does that sound too much, unreasonable? I'm okay if someone has a better idea.
I think it's a great idea. Yeah,
Okay.
I think it's a great idea.
So Alexa, if you can do a Google document that would include Brian, Barb, Patty, Steve, Vicky. Am I missing anyone?
And if we could add Cheryl Hikes as
Yep.
well.
Add Cheryl. You know, I'm all about deadlines. So, and I'm sure people probably have vacations scheduled in here as we're entering into the end of July or August. So let's say by September 13th. Does that sound fair? That gives everybody plenty of time to scroll through and see. We'll have a draft for you within that week of September 13th to get the go-ahead. How's that? And then it is up to you to get this information out, but it would be agreed upon by everybody who's put their information in of how this works. Okay. This is the quiet this group has been this whole entire time. I don't know whether to be afraid or not.
We think it's a great idea. It's a great idea.
Okay. So the last outstanding recommendation, number 3, identify the barriers for opening acute care facilities for behavioral health. Patty, you unmuted, you're up.
No, I think that it's a. I'm not sure. I'm not sure if acute care facilities for behavioral health is the proper name for it. It's facilities that can care. I think it's facilities that can care for patients who have behavioral health diagnoses longer term. So I don't think it's the acute phase of behavioral health, because I think the hospitals have acute behavioral health, but it's the person who has, like, the traumatic brain injured individual who survives that trauma, has now been through the physical rehabilitation, but has a long-term traumatic brain injury, so has a more of a longer-term behavioral health that needs to be cared for. I don't know, Barb, what you recall this?
Yeah, I think that's one part of it, but the other part is we have patients that have behavioral health needs, but they also have some medical needs, like perhaps they have a feeding tube, or maybe they have a Foley catheter or something like that. And that's the only thing that prevents them from going into a behavioral health facility. So they have to stay here in the hospital because the facilities won't take them with those particular items. They say that they're too medically complex to go into the facility. And those are really minor medical issues, but it makes them stay here.
So maybe then it is the right term, the acute care behavioral health, because as you indicate, Barb, yeah, that's a different scenario.
Mm-hmm.
Lexi?
Yeah, I think I would probably suggest, identify the barriers, identify the pathways, because as Barb says, people with behavioral health issues and also level of nursing, that need nursing home care, there is no placement for them. They do stay there. So I think identifying the challenges and also finding the pathways forward So it says identify the barriers. I mean, the barrier is the mental health aspect, I think. And so the pathway forward is how do we open up the nursing facilities to people who have mental health issues as well?
Okay. I just came across this scenario and I don't know if this really is pertaining to acute care, but a patient who has been residing at one of our mental health facilities, it doesn't relate to the acute care as I'm thinking through this, but very similar, Patty and Barb, to the situation of someone being in a facility for a longer time than they need to be. This patient is a Medicaid patient, and they have the power of attorney has their own medical issues, has been in and out of the hospital themselves. So there's no one to release this patient home. Patient is secure, patient is been ready to leave. Also can't get a nursing home to take this patient. So I actually invited that particular group to join us today. Unfortunately, they're not here with us, but it's the same scenario, right? Like that patient should not be sitting in a behavioral health facility, but has nowhere else to go. So
that is the scenario. And that is the challenging, because you want them at the appropriate, least restrictive level of care. And if they're ready to go home, but there's no mechanism, the person who has the authority or power to do that is not available, and they could go to some other lower level of care, you certainly want to get them there.
Yeah.
So I don't think we have the answers yet for these types of more complicated or complex cases where, you don't want people just living necessarily in facilities. You want to get them to the appropriate level of care.
So you know what, Patty, let me do this. I want to make sure. So Alexa, make sure that that we're adding Senator McBride, myself, Representative Benz. I know I'm leaving Representative Minor Brown. There is a group of us that are putting, I will say Nemours is being helpful right now in pulling this together. You should be expecting a call, Patty, in regards to mapping. But we are going to be putting a summit together that will happen September, October, November in regards to behavioral health and what it looks like in the state of Delaware. This has been a huge topic for me for over the last year and a half. Actually, many of us. I don't want to take the credit that it's only me. It's not. We've got House Bill 100 from Representative Longhurst that once we go back into schools and the counselors start identifying children that are going to need, crisis intervention, where does that lead? Where are we going with that? And to this point, you have a broken arm, you need stitches. We're running to the ER department. With behavioral health, we can't see it. We don't know enough about it. And so we come to you as the experts in the emergency room to help us manage through this. So there's going to be some deeper dive conversations in regards to behavioral health. I think this reflects back to identifying the barriers in the acute care setting and then finding the appropriate places, right? And I think Delaware, we can do so much better in what we need to provide for our young, for our young adults to our adults. So I want to make sure that not like you're doing anything else, right? Let me add one more thing to.
And Barb.
Yes, and Barb. Let us add one more thing to your plate. But I think the conversation.
It's very important work. It's
Yes.
very important work, and happy to see that it's, that there's going to be, an opportunity to address it. It's super important work.
Yes. So I want to make sure that both of you, if you're willing to follow along to join that, We were just creating a list last week of folks that we think we should be there. And I think that this would be a good transition from this committee into the next one. Suzanne, I saw your hand up, and then Lexi, your hand is up as well. Oh, nope, your hand is not up. So Suzanne, your hand is up.
Thank you. So I've not been part of this entire conversation for the term of the task force, and maybe I misunderstood a little bit about what, Patty, what you were saying, but when it comes to mental health, behavioral health settings, that's a different process than the guardianship process. A guardian cannot commit someone to a mental health facility. And so, Patty, I'm not sure if I didn't hear accurately what you were saying, but I just want to make clear that that's not a guardianship process. That's a civil commitment process through Superior Court, not the Court of Chancery.
Yeah, yep. Thank you for that. Let me just provide some clarification. This is not a commitment for someone who needs acute behavioral health, is a danger or to themselves or harmful to others. This is one of the scenarios. So the scenario I was sharing is the person is fine today and goes out and gets in an accident on I-95 and now is a traumatic brain injured person. They survived the accident, they're acutely recovered, they have had physical recovery, but mentally they are changed because they've had a traumatic brain injury. So now they need a long-term facility that will handle traumatic brain injuries because they behaviorally act out in very violent ways. So you're not committing them to the facility, you're looking for the next safe level of care for them. So it's not a commitment, and the guardian does sign them into that facility in order for them to receive the care at the appropriate level. What Barb was describing is a little bit different, and I'll let Barb re-describe her scenario.
So my scenario is someone comes in who does have an acute behavioral health need. Either they're have suicidal ideations, or they're on a 24 or something like that. And we're wanting to get them placed into a facility, a behavioral health facility, but they may have a Foley catheter, or they have an NG tube or a PEG tube or some type of medical device that they need, to sustain their life, but they can't get into a facility because none of the facilities will take that. That's a too high of acute level of medical care. So those are the things that we struggle with.
Suzanne, does that help?
Yes, and those are issues that families have tried to cope with for years. And I guess I was just thinking that was beyond the scope of what this task force was looking at. But, as I say, I came into the process a little bit late.
No problem. Lexi, your hand's up.
I just wanted to add one more thing to the scenarios that Patty and Barb sort of put together, because it's very similar, but I mean, and it goes to Suzanne's question as well. Certainly a guardian cannot commit someone to an acute care mental health facility, but we frequently have people who have both behavioral health, acting out issues, who can't find a nursing home placement because of those issues. So it's all the same thing. It's like a triangle there. I mean, both those scenarios are good. And there's just a third one where you're trying to find a nursing home level of care and the mental health issues get in the way, or not get in the way, but they're hard to get addressed at the same time.
Mm-hmm. Steve, I have a question. Nationally, are you seeing or hearing some of these same things?
Nationally, we're seeing this. In Delaware, we are certainly seeing this. We hope to be able to address this, at least to some extent, as part of our American Rescue Plan home and community-based services spending opportunity. And I invite any of you and all of you to participate in our public listening sessions and to look to our website for the initial plan that we submitted to CMS, which is extremely high level and philosophical at this point because we chose not to allocate that money without a broader stakeholder process. It is $52 million approximately that Delaware will be able to receive based on our HCBS spending this year, but we have 3 years to spend it. And it is designed to address, to help states actually address some of these systemic issues. I wanted to jump into this conversation, but then I was hesitant because the water is so deep and there are legal issues that I would never want to opine on with so many attorneys on the call. But it is extremely complicated. And I think the scenarios that you heard illustrate how complex it is and how the solutions are really gonna differ depending on that scenario. I think I would agree with Suzanne, however, that they're largely not guardianship issues. They are system design issues and barriers to services for people whose needs require multi-systemic responses. And we have systems that are pretty siloed and aren't always good at that. It is particularly challenging when you are dealing with the behavioral health space and many of the rules and regulations around institutions. I'm going to say this, I hate the term because it's so archaic, but it's the official term, institutions for mental disease, but your inpatient mental health facilities. So we are finding more and more people who end up in the emergency room for one reason or another, and then it is extremely challenging to discharge them from that setting or the larger hospital setting because there just is an appropriate place for them to go. Their medical needs may be too great for a behavioral health facility, or it may be inappropriate for them to go to a behavioral health facility because while they may have behavior needs, they do not have a diagnosis that really warrants admission to a restrictive behavioral health setting of that nature. We have the protections for the individuals around what public guardians can and cannot do as far as approving admission to certain types of facilities, because it really is more of a civil commitment issue. So those are really, really, really complex, and I think absolutely warrant stakeholder involvement to try to address them. And I can't believe I'm going to say this, but that's probably for another task force to address.
Yeah. And Steve, that's where we're heading now. I'm hoping that, and I've used the Guardianship Task Force as an example, that many of you in your industry with the specialties that you have were able to collaborate with one another. Some of the easiest fixes that we would have anticipated would have been mountains to climb were easily done just by sitting around the table and having conversations. And plus, I know many of you have forged relationships that now you certainly don't need myself or Mike or David to help you make any of those calls. You're making them yourself. So you're making lives much better for people in Delaware. So, so we are heading in that path. We're hopeful that the conversations over the next couple of weeks, which you too will be invited. And so as we're getting that list together to have people sitting around the table. So, you know, anticipate seeing that because you are a big portion of how people are going to get served. So Appreciate it. And thank you for sharing that. I know several of you have already texted me to say you'll be on the website. You'll be looking at the website. So I would highly encourage you in your practices to make sure you participate in this conversation. Lexi, your hand's up. I'm not sure if it's intentional or not. No worries. Okay, so I'm not sure we necessarily really identified or found the solution for number 3. I almost feel like that is going to be a continual conversation in the next set of meetings that we're going to be having, which don't necessarily connect with guardianship, but because of all of you being such great participants in this task force, you know, I would encourage you to join that information. And I'm happy to have Alexa send that information to you once we start getting those dates set up. So I think our takeaways, let's go back to number 2. So Steve, come on back up into the box, please. We're going to reflect back to work completed. And the question, I'm not sure if you have the document in front of you.
I do.
Okay, great. So improving access to court-appointed guardians for individuals residing in a nursing facility. The question was, is that the nursing facility is to utilize their gross earned income or personal needs allowance. So we just need clarification. Is it gross earned income or personal needs allowance?
Gross earned income.
Okay, great.
Still have their personal needs allowance.
Perfect. Okay, so that clears that one. The next part of it is related to, we were talking about covering the attorney ad litem fee, which I believe one document had said we were covering $750, and that is accurate.
Yes, I pulled out the document. That's the initial establishment fee, which is then followed by the $100 monthly allotment.
Okay, so Suzanne, you got your answer? Okay, that's fantastic. Steve, you did a great job on that state plan. Thank you very, very much for the clarification and helping bring this full circle.
Thank you all for helping us to find our way on that.
Okay. And then the last thing that the only really thing that we have left that I am looking at my notes is that Google Doc and having some input into what like the slick sheet looks like of the process on this. I'm sorry, let me reflect one more thing. Patty, do you still need the process written out for item 2? Because you said need process document guiding principles on how a hospital knows what to do.
I think so, and I'm looking to Barb here. I just think, you know, Barb and I have been in this meeting and this task force since the beginning, right? So we hear it, we have an understanding, but we're not going to be the person necessarily doing this work in the emergency room. So I think for consistency and clarity, I think it would be very helpful to have something in writing about that one.
Yeah, I agree.
How it works. Okay.
Yep.
So, and it might be something, you know, we could take the process flow that we did and said, okay, where does this plug in? And if we could do that, the hospitals then could probably draft a process and run it by Steve, your team, to say, do we have this right? You know, we do have that whole process flow written out, and it might just be something we could plug into the process.
Yeah, and Pat, maybe that would be a good approach, because I'm not sure what exactly you need in the way of guidance, because we would not be providing any guidance on how to get access to a public guardian. We would just need to be aware that that has happened and what those expenses are when we are doing the post-income eligibility processing of the application.
So
And
we would need to
Okay.
thank you.
we would need to see a copy of the bill so we could protect the client's income.
Okay, so, all right, so I think that we could draft it from the acute care side to say, this is what we're going to do, is this correct? And then what do you need in order to do that? Okay, we can do that.
Okay, so what I'm hearing is that Patty, Steve, Stacy, Barb, you guys will be working together to complete this piece of it in the
Yeah,
processes.
Barb and I, yeah, we'll engage the acute care case management teams from all the hospitals to say, this is what has been passed, and this is how it gets operationalized, right? We're gonna create a draft for all the hospitals, so they all understand it works the same way, and then give that to Steve and Stacy or your team to say, yes, that is correct, and this is what we need in order to, we need the bill, we need to understand what the Guardian is charging, or how they get reimbursed, or how that works. But we'll do it from the acute care side, and then Steve and Stacy can correct us.
Okay, that being said, once that is written out, is that something that we're also flipping to Brian so he can post?
I think that.
I think, yes, that would be, I think that would be helpful.
Okay.
I think it would also be very helpful that we share this with the post-acute care facilities. So, Cheryl, Vicki, we can certainly in our node collaboration meetings that we have with the post-acute care facility, let them know that we're working on this, because these are sometimes going to be residents that live there already, that they can start working on these processes. Right. Before they even come into the hospital, because some people they're fine in their nursing home, they're cognitive, they can do, they have their own decision making, but then as they start to decline, the skilled facilities could start working on this before they even come in.
Okay, great. I just want to make sure that the communication continues, right? It doesn't just stop with three of you and then a year from now, someone saying, hey, well, we don't know what the process is.
Right.
Is there a way
that's a good idea.
to then for the courts to make sure we have it for the guardians? Because I think that would then close the loop. Would be great.
Okay, so here's what's going to happen. So Patty, Barb, Steve, in case I'm missing anyone, I apologize if I'm leaving you out. That's not my intention. You're going to be working on what that looks like for the process when it is completed, which it would be really cool if you had it completed by September 13th, right? When we're talking about finalizing everything else, then we will have Alexa send that out, that final document to this group. Again, this goes back to each one of you, posting, pinning, sharing, and making sure that this information is disseminated in the prospective fields. So that way the process is out there. And Brian, you'll do your own thing on your website and get it out to your peeps, right?
Yep, we'll disseminate it, absolutely.
Okay. Does that sound like a plan, everyone? Okay, so two items left, and they are our 2 items for September 13th with a finalized document within that week and out to everyone. Does that sound like a good plan? Okay. All right, at this time, any questions or concerns from this committee?
Senator Poor, before we conclude, there was a final, not full recommendation, but something that we decided needed future discussion. Is that something that you want to omit from the final report or include that it needs further discussion? It was at the end about creating an office in each hospital.
Oh, goodness, I missed that one. Thank you, thank you, thank you. Didn't scroll all the way down. Create an office in each hospital that can place people in the least restrictive environment based on the individual's preferences, circumstances, and needs. So this goes back to the hospitals. And it sounds like, from what I'm hearing, you've added case managers to your primary care offices. I'm gonna let the Barb and Patty speak on this, and also Vicky, if you would like to, on skilled nursing facilities.
Yeah, I think from the acute care perspective, and I certainly look to Barb as well, items 2 and 3 above, and 4 actually, 2, 3, and 4 really address this particular item. I think this was an early on idea to say, you know, we just need a trusted person of the court to be able to move the patient to the least restrictive environment. Can we create an office in the hospital? I believe there's language in the guardianship statute that prevents the hospital from serving in that role. So what we did was we addressed this through items 2, 3, and 4 above is my understanding. But Barb, again, looking to you for your opinion here.
I agree that that we've addressed the majority of it, although part of the problem is the length of time that we need to move someone from the acute care while all of these things are happening. I still think that that's an outstanding issue. I don't know how we shorten that time frame. I do
But
know.
we've shortened it to, what's that, 30 days? 30 days max now that, you know, we give the families 2 10-day periods. I can't remember it off the top of my head. Two 10-day periods to respond. So we've taken it from infinity down to, I think, 30 days, right? Isn't that, so that number 4 has really helped.
It really has helped. And yeah, I think that we've really moved forward on it. So I don't think that we need to have the future recommendation. I think we're good with what we have right now.
Yeah, I think we're good as well.
Okay. So let me open it back up to the task force and ask if there are any questions, concerns, any final comments?
Do we need to approve the minutes from the last meeting?
That was my question, and I actually had a couple things in my notes and some suggestions, 1 or 2 suggestions about adding information into the minutes for people who may like go to the website to look at the minutes and maybe not check all of the exhibits that had been distributed.
Not sure I know the answer on that one.
Could you repeat that one more time, Suzanne? You said about do you mean adding like an appendix to the minutes or?
No.
Oh, okay.
No. So for example, in my notes of the meeting, of our last meeting, Steve talked about establishing what I'm on page 1 of the minutes down at the bottom, set aside to pay. And I would just say, can't we include up to $100 per month for guardianship services? Just so that people don't have to start digging through a bunch of data. And then the other note that I had was that, and my note said Mary Kate McLeod, I'm not sure, and she referenced the Swank Memory Center, at least as I wrote it down, and that didn't make it into the notes. In my note, where I took notes, she had commented after Ms. Hikes.
I understand now. Thank you.
Master Griffin?
just a quick procedural, make sure, and I apologize, for the final report, is the plan sometime, you said mid-September to send it out, then we would give our final comments? Would we have another meeting? Is that the idea? Or would we just do that by email? You may not be able to do that by email. What's the, and I apologize, I probably just missed this.
No, that's okay. Technically, this task force is concluded. We concluded it at the end of the General Assembly. We extended it to do this meeting because technically we had met all of the requirements based on the original task force. Our conversations were so in depth and also so good in order to do some additional things. And that's why the task force continued. So we are at a point now where I believe we should be able to do the final report and send it back out to everyone. Because really the rest of this is just tidying things up.
Great, thank you.
Does that work for everyone? Look, I'm open to anything, but I would say that we have, Master Griffin, to your point, we have already, we've exceeded what we needed to, and really some of this is just tying up some loose ends. Patty, you're unmuted. I wasn't sure if you wanted to.
I mean, I'm fine. I'm fine with that approach. I'm fine with writing up the report, sending it out. I think we've covered all of the outstanding items. Again, Barb, from acute care perspective, wanted to ask you to weigh in.
Yep, I agree. I think this has been really, really good. Appreciate everybody working so hard to, to come to this point.
Yes, and hopefully I see everyone in.
Oh, absolutely.
Great. And also referencing back Steve and his group's hard work in making sure that they're using the rescue money and what does that look like? So attending his meetings in the future as well. Great.
Senator Ford,
Yes.
we still need to technically approve the minutes. Suzanne proposed 2 different edits that I'm going to make, but we still have to vote to adopt them with the impression that there's going to be those 2 edits from Suzanne.
Okay, so if you can restate those edits.
Yes, so Suzanne said that in Steve's description of, I believe, the state plan amendment, I'm going to make sure that's a little bit more in depth because the state plan amendment attachments are not public yet for everyone to see. So that will give them a better grasp of what we're trying to say.
Right, and so that would include the $750 fee for the attorney ad litem, as well as the $100 monthly.
Correct.
Yes.
And the other edit was something that Mary Kate had said after Cheryl, and she had specified a certain facility or term that I can go back and find in the footage and make sure that's reflected in the minutes.
Okay, great. With that being said, can I get a motion?
So moved.
Second.
Thank you. All in favor?
Aye.
Anyone opposed? Okay, fantastic. Well, we have concluded. By the week of September 13th, you will all have documents back out to you that I ask that you share. And if there are any other questions or concerns, you all know how to reach me, Representative Mike Smith. Thank you so much for joining this task force and participating. Representative Benz, thank you so much for co-chairing in the middle of this task force. I appreciate all your supports, and to our staff that kept this moving month after month. Thank you very much.
And we have to open the meeting up for public comment now. Sorry.
Little rusty, come out of session and all of a sudden you're rusty on how to run a meeting.
We'll now open the meeting up for public comment. I don't currently see any attendees, but if there are anyone that would like to provide public comment, please now raise your hand. Seeing none, that will close the public comment period.
Okay, wonderful. All right, everyone, thank you so much for your time and your energy.
Thank you. Thank you very much.
Thank you
Thank
for your
you.
leadership.
Thank you.
Bye-bye.
Thanks.